I'm going to present a case of secondary optic nerve atrophy secondary to a rare infectious cause. We got a patient of 30-year-old male presented with complaints of decreased vision in both eyes for 1.5 months, which was sudden in onset and painless in nature, and it is not associated with any other ocular symptoms. No history of smoking or alcohol, no history of trauma, no history of any complaints of reduced vision in the past, and usage of any spectacles. Previous medical history said that patient has a history of fever, altered sensorium, and fever, for which he was hospitalized for 2 months and on tablet doxycycline and steroids. On ophthalmic examination, his visual acuity of continuing at 3 meters with no improvement on pinhole test and with glasses in the both eyes. And on torchlight examination, there was sluggish pupillary reaction to the light and nystagmus are noted. Extraocular movements are full and normal. On slit lamp biomicroscopic examination, anterior segment is within normal limits with normal intraocular pressure. On evaluation of fundus, both eyes revealed temporal disc pallor and with dull foveal reflex. On OCT on optical coherence tomography of optic nerve, we got there was RNFL thinning in the both eyes is noted, and also the macular thinning in both the eyes, and with right eye subretinal fluid also is present. These are the pictures of different radial line scans. On fundus fluorescent angiography, there was enlargement of foveal avascular zone, which indicates macular ischemia, and visual fields could not be done because of nystagmus. And hence, based on this history, examination, OCT, and FFA findings, we reached a probable diagnosis of optic nerve atrophy with macular ischemia in both eyes. Based on only ocular examination, the differential diagnosis are post-infectious optic neuropathy and neuroretinitis, or post-papilledema, a traumatic optic neuropathy, or nutritional or toxic optic neuropathy. The lab investigation when hospitalized was done on complete blood count, which showed thrombocytopenia, and serology, which was negative for dengue, HIV, and HPS, and it is positive for Weil-Felix test, that is rickettsial infection. And diagnosed to have meningoencephalopathy and thrombocytopenia secondary to rickettsial infection. The patient received appropriate treatment along with platelet transfusion and was discharged after his vitals were stable and platelet count were normal. After the systemic investigation, we came to the diagnosis of optic nerve atrophy with macular ischemia secondary to any rickettsial infection. Coming to the discussion, rickettsiosis is caused by rickettsia, which are obligate intracellular gram-negative coccobacilli, and it is transmitted to the human through infected arthropods such as mites and ticks. The rickettsiosis produces occlusive vasculitis by infecting smooth muscle cells and endothelial cells of capillaries and small arteries and veins, which causes increased vascular permeability, fibrin and platelet deposition, which cause occlusion of blood vessel, and which results in death of tissue. The ocular manifestation which were reported before or by vitritis, retinal lesions, retinal vascular leakage, and optic disc swelling and optic neuritis, which are of rare occurrence. In our case, patient presented to us 2 months after the onset of his fever with pale disc, suggestive of secondary optic atrophy, most probably due to direct invasion of microorganism. Weil-Felix test, which is considered more than 1:80, is positive. Conclusion: it is important to do an ocular examination in a patient who presented with history of fever. Hence, it can be diagnosed and treated early to avoid irreversible vision loss due to optic nerve damage and macular disease. Thank you.
Where you see a bilateral optic atrophy like this, would you not consider doing a VP in such a patient to know the visual loss?
Yes, ma'am. But he didn't come for the follow-up again, so we didn't do the proper, fully is not investigated.
And beyond the Weil-Felix test, is there no other supportive test which suggested you that you were very sure that it was rickettsial?
RT-PCR can be done.
Right.
PCR can be done.
Yes.
Neuroimaging MRI was done, sir, but he didn't have the report. It was done outside. We had the prescription of the doctor, so it says encephalopathy. We didn't have that proper MRI report.
And why there was nystagmus? You said there was nystagmus.
Yeah, yes, sir. He got nystagmus after that encephalopathy only. Might be due to brain lesion.